so we can kickstart everything. So, Prof, you can kindly take over. Thank you very much.
So just checking the audio. I mean, can you hear me well?
Yes, Prof is very fine. We can hear you.
Very good. So welcome everybody. And already we are at session number 6. I mean, so time is really flying past, and we're covering a lot of aspects. So as I mentioned yesterday, or was it the day before, like when we had our previous session on session number 5, today we're going to be talking about Ctg interpretation, that is electronic fetal monitoring, which of course, I mean, with all its pros and cons, I mean, it is, I mean, it's a tool which is part and parcel of most deliveries which happen in hospital. So I think since we do rely quite a lot on it, I mean, even to base our decisions when it comes to delivery, okay, and unfortunately with medical legal aspects, I mean, you know, it's whether you like it or not, I mean, the monitoring is a tool which, I mean, needs to be used, let's say. I mean, especially in, as I said, I mean, when you're delivering in hospital. So there are, of course, many different ways of interpreting Ctg, but what we're going to be covering today is, let's say, again, another mnemonic, you know, like what we did when we did the assisted vaginal delivery. And the idea is that there is a more or less standardized way of how to interpret Ctgs. That in times of stress, in times of emergency, like it goes kind of in your subconscious. And like that, I mean, if there is that standardized interpretation, the risk of misinterpretation or mismanagement is reduced. Okay. All right. So the way we're going to do this session today, as I said, it's going to be a bit more interactive. So I will be spending probably the first maybe 30 minutes to 40 minutes where I'll be giving a brief overview of what electronic fetal monitoring entails. Also, I'll then describe the mnemonic. It's called Dr. C. Bravado. I'll describe the mnemonic so that you are familiarized with it. I mean, you might already be, actually. And I'm sure you're all very well versed in how to interpret CTGs. But the idea, as I said, is that there is a standardized way, which we do find that it is helpful, especially, as I said, when it comes to emergencies. And unfortunately, if a case is taken for medical legal issues, which I can tell you in my 30 years of practice, I mean, when I started off, you know, it was unheard of that, you know, a doctor or a medical team is ever taken to court. But I mean, as you know, time goes by, it's getting more and more and more common. I mean, in mainland Europe, it has been very common. And yes, I mean, it is a fact. I mean, it is true that sometimes the medical profession does mistakes. So yes, I mean, there are times when patients are right, but I mean, of course, if we're all humans, and if we help ourselves by having standardized ways of how to having guidelines of how to deal, you know, with emergencies, then that makes us safe, and it's safe for the patient, safe for the baby, and of course safe for all the team. Okay, so let's start off. Okay, so what we're going to be doing, as I said, I'm going to be giving you a bit of a background on electronic fetal monitoring, comparing also electronic fetal monitoring to intermittent auscultation, like structured intermittent auscultation that is using either the Pinard or the Doptone. We're going to touch a bit about on the physiology of electronic fetal monitoring, discuss some recent developments, and then we're going to dive into the systematic approach to electronic fetal monitoring interpretation. That is the Dr. Sibravato, the mnemonic that I'm going to be talking about. So, structure intermittent auscultation is what is normally used for local risk women, especially if they're not delivering at hospital. I mean, if there is a home birth or in a birth center, and low risk women normally, you use the dop tone or the ultrasound if there is access to it, or the pinner stethoscope, in order to be able to listen in and to make sure that the fetal heart is normal. And the recommendations, I mean, these are taken from the NICE guidelines, and the NICE guidelines, NICE actually stands for the National Institute of Clinical Excellence, and they're issued from the United Kingdom. We in Malta, being Commonwealth countries, I mean, we do follow quite a lot of guidelines which are issued by the UK. But to be honest, I mean, these guidelines are also very similar, more or less, like you have in mainland Europe. And again, they are guidelines, which of course, I mean, depending on the patient, I mean, you might need to adapt those guidelines accordingly. So basically, these NICE guidelines, what they recommend is that during labor, active labor, every 15 minutes, you listen in the first stage, and every time you listen in for 1 minute after a contraction. So as I said, you can either use the pinard or the top tone. And then during the second stage, where of course there might be a bit more room for fetal distress, you listen in a bit more frequently, that is every 5 minutes for 1 minute after a contraction. So those are the recommendations. Now, what about electronic fetal monitoring? So electronic fetal monitoring was introduced in quite some time ago now, I mean over almost 50 years, right, 1970s. And the idea was to make delivery safer. So the aim was that rather than just listening in intermittently, you actually have a machine which can monitor objectively, sort of, rather than relying on the midwife or the obstetrician who's listening in, but you have an objective way by having a printed trace, basically. And the idea was, I mean, good, because the idea was to reduce perinatal mortality and morbidity, and especially cerebral palsy. Okay, so to have safer births for babies. The truth is that it was taken so obvious that once you have this EFM, it's obviously going to do good and no harm at all. However, with time, there were many randomized control trials carried out, and sadly, they didn't confirm improvement in all of these outcomes. And what definitely has happened, I mean, partly because of the more monitoring, partly because of more, let's say, institutionalization or medicalization of birth, and also because of the changing demographics. So women who previously maybe wouldn't have had babies now are having babies. Also, I'm referring to elder mothers, mothers with certain medical complications. I mean, now we're seeing, a changing demographic in women having birth. And therefore, what has happened is that, of course, if the electronic fetal monitoring is showing you that something might not be right, that does trigger more obstetric intervention, right? So more likely to expedite delivery, whether it's assisted vaginal delivery by forceps or vacuum, or by cesarean section. So when I mean these are a number of randomized control trials show this. So in reality, yes, I mean by during labor, I mean monitoring using electronic fetal monitoring has led to a reduction in neonatal seizures, right? And hence, neonatal seizures, of course, can lead to cerebral palsy. So there has been a reduction there. However, there has been no documented evidence of reduced perinatal mortality, and even, unfortunately, no evidence of long-term of decreasing the incidence of long-term neurological handicap. So unfortunately, neonatal outcomes, they have improved, but not as much as they were expected to, right? And at the same time, it has led to an increase in cesarean section rate and an increase in instrumental delivery. Now, of course, over these past 50 years, also cesarean section admittedly has become safer, right? And some women actually requested. So I don't think that the 66% increase in cesarean section rate is purely attributed to electronic fetal monitoring. But certainly, if you have an abnormal trace, you are more, you kind of are bound to act on it. So the whole point of today's session is not, of course, to say that electronic fetal monitoring is not useful. It's there, it will have to stay, and I don't think it will ever be removed from neighborhood. If anything, it will be modified. You have more machines which are more accurate. So our role is to be able to interpret it better so that, right, we intervene when needed, but we don't over-intervene, right? Because over-intervening does mean then more cesarean sections, instrumental deliveries, So the Ctg, basically the conclusion of the randomized control trials where they've been comparing using a Ctg versus just using intermittent auscultation. So a normal tracing, you get a normal Ctg as long as you interpret the normal tracing well, okay? And we're going to see that sometimes a normal can be mistaken. An abnormal might be mistaken for a normal tracing, but if it is a normal tracing, a really normal tracing, it is predictive of a good outcome. So having a normal Ctg means that, yes, very likely the baby will be born healthy and normal, not respiratory distress. However, what we label as a non-reassuring or pathological tracing, which will be seen, a number of these tracings today in our practical session. However, it is not good really at predicting a poor outcome. So having an abnormal Ctg doesn't necessarily mean that definitely the outcome is going to be poor. However, in spite of what the randomized trials say, very often, if there is a pathological tracing, you need to do something. You need to intervene. Now, whether it is putting a fetal scalp electrode to measure the oxygenation of the blood of the baby directly, or whether it's expediting delivery with assisted vaginal delivery or cesarean, or maybe even changing the position of the mother during labor, okay? But it would need some kind of action. It would be a drastic action like cesarean, or a less drastic action like turning the patient on her side when she's delivering. So let's just touch a bit upon the physiology of fetal heart rate changes. So fetal heart rate, right, they do change in response to changes in oxygenation, oxygen levels in the fetus, and of course the oxygen levels that it's receiving via the umbilical cord, right? CO2 changes, H plus ions, right, that is the pH, and arterial pressure. So the fetal heart rate responds, same as our heart rate, right? It will respond to biochemical changes, so changes in the partial pressure of oxygen, carbon dioxide, pH, and even the arterial pressure. And all these changes are mediated via the parasympathetic system, so basically the vagus nerve, and chemoreceptors, which are present in the heart, and even these carotid body baroreceptors. What are these? Carotid body. So the carotids are the arteries, which are branches of the aorta, and they go and to supply the brain, okay, the head and neck and the brain. And within these carotid arteries, there are what we call the carotid body. There are these baroreceptors. There are these receptors basically which detect changes in the arterial pressure. These are in the baby, right, in the fetus. So, of course, it is not easy to directly measure the level of oxygen in the blood in the fetus and the level of pH. I mean, you can't, have an arterial line or something attached to the fetus during delivery to measure directly the oxygen levels and the pH levels. Therefore, CTG is used because the fetal heart rate, which is measured by the CTG, will indirectly assess the fetal acid-base balance, and also which of course is dependent on the fetal oxygenation. I mean, if you were to directly measure the oxygen levels in the fetus, that's more invasive. And I mean, it is possible to do it by attaching, I mean, like applying like an electrode to the fetal scalp. So, or else, literally making the nick in the fetal scalp as, during delivery, and taking a sample of blood from the fetal scalp and measuring the oxygen levels there. But of course, it's invasive. And that's certainly not something that you're going to do before the fetal scalp, I mean, is visible. That is before the complete engagement and, I mean, imminent delivery. And you can't keep on nicking the fetal scalp just to take oxygen because it's causing trauma. And therefore, electronic fetal monitoring is an indirect measurement of the fetal acid-base balance, which is a measurement, a direct measurement of fetal oxygenation. Now, what about continuously doing electronic fetal monitoring? So, the guidelines say that it should be individualized based on specific risk factors. So, if someone is at high risk, all right, and is at high risk, especially of having a poor perinatal outcome, that is, babies at risk, or if you have a low risk patient, but during labor, the risk status changes. For example, she starts experiencing bleeding, or the blood pressure goes up, or there is slow progress. So, yes, I mean, there are fetal maternal labor indications where you need to assess continuously. As I said, if you're dealing with a low risk pregnancy, right, from beginning to start, then intermittent auscultation or intermittent fetal monitoring, let's say 20 minutes at a time, that's fine. But continuous, that is, literally having the patient attached to the machine throughout labor. I mean, that should be, the guidelines say, only when there are indications. And what are these indications? So there are fetal indications if that makes the pregnancy high risk. So if you're dealing with intrauterine growth restriction, oligohydramnios, previous abnormal Dopplers, usually done because of IUGR, if there's preterm labor, if you're dealing with multiple pregnancies, so twins or more, the baby's breech, of course, because of the risk of cord prolapse, and of course, rhesus immunization, which you know, as we mentioned in one of the previous lectures, I mean, hopefully we see less and less and less because of the screening of the maternal blood type before and even receiving the anti-D, you know, when she is rhesus negative in a previous pregnancy. There are maternal indications where you need to do continuous electronic fetal monitoring, and these include VBAC, which is vaginal birth after a cesarean. So when a lady has had a previous section, and let's say the previous section was particular to that pregnancy. So, for example, she needed a cesarean section in her first pregnancy, for example, because of breech presentation or twins. And now she's pregnant again, and she would like to go for a normal delivery, then yes, I mean, because of a previous scar in the uterus, a previous cesarean scar, then yes, that's indicated to have electronic fetal monitoring, of course, because of the increased risk of uterine rupture. Of course, if there are pregnancy-related complications like preeclampsia, if you are post-base, like post 42 weeks, if there has been prolonged rupture of membranes of more than 24 hours, if the mother has diabetes, whether gestation or full-blown diabetes, if there has been antepartum hemorrhage, if the mother has significant medical conditions such as cardiac, neurological, or renal, and if the mother herself requests that she wants to be monitored. I mean, that, to be honest, doesn't really happen that frequently because you can understand that being stuck to the electronic fetal monitoring does mean that she has reduced mobility. And so, and it's not usual that mother is requested, but it's usually more it's from the medical point of view that it is requested. And you can have labor indications. So, for example, you still have a low risk pregnancy, but you need to augment with oxytocin, or suddenly there's intrapartum bleeding, or suddenly the mother develops high temperature, there's pyrexia, or the liquor suddenly becomes meconium stained. Or, of course, if you're doing the intermittent auscultation, and upon auscultation, you realize that there's an abnormal fetal heart rate, so tachycardia, bradycardia, or decelerations. In that case, it is indicated to switch to continuous electronic fetal monitoring. So, in order, as I said, to make it safer, I mean, it is recommended that there is a systematic approach to Ctg interpretation. And why is that important? Because the person who is monitoring the lady during pregnancy, during delivery, right, be it the birth attendant, the midwife, the doctor, it's important that you know, if you are monitoring that labor and you realize that something is wrong, right, then action would need to be taken. Okay. So, what I'm going to be talking to you is this mnemonic, it's called Dr. C. Bravado, okay? And it's a mnemonic, as you can see, where the DR, the doctor, you start off by determining risk. So the lady that who has come in delivery suite, I mean, is she low risk or high risk? The C is the contractions. So as you know, I mean, the electronic fetal monitoring, you get two belts. The woman has two belts around her tummy. One of them is measuring the fetal heart rate, and the other one is measuring the contractions. And this we're soon going to see. They need to go hand in hand. I mean, especially during labor, because as you are seeing the changes happening in the heart rate, they are whether they are normal changes or abnormal changes, you are able to make the decision based on how they're changing with the contractions. Okay. Plus, the contractions themselves can tell you a lot of things. So, apart from the frequency And apart from the frequency of contractions, and because the CTG, by the way, doesn't really tell you much about the strength. The strength is when you put your hands on the mother's tummy, and from there you can assess the strength. It's the frequency that you can measure from the CTG. But how the fetal heart rate is changing with the maternal contractions, that makes a difference as to what type of decelerations, for example, you're getting. And there are ones which are, not harmful, but others which warrant some degree of intervention. So this is C, contractions. The BRA is the baseline rate of the fetal heart. And we'll soon see like what we mean by baseline rate. That's followed by the variability in the fetal heart. We'll see that also to see what it means. The A stands for accelerations, right? So when the heart rate increases basically and then goes down again, accelerations. Decelerations, which is the reverse, so when the fetal heart rate goes down and then recuperates. And these decelerations, depending on whether they are early or late, and what makes them early or late is their relationship to the contractions. And finally, the O, your overall assessment, your plan, and what you're going to do if you need to do anything. Okay, so Dr. C. Bravado. So let's just dissect it a little bit so we understand, what each stands for. Okay, and then following that, we'll have I prepared about 14 different traces, 14 different cases, and we'll have the opportunity to discuss them together. Okay, and as I said, there's no right or wrong, but we're going to discuss them and like put ourselves in the shoes of the doctor on call, right, or the team on call, to decide together what type of action would be taken. But let's go through this, Dr. Bravado first. So the DR, as I said, stands for determining risk. So are we dealing with a high clinical risk? Is it a low clinical risk? Is it a medium where you need to watch a bit more closely and watch them more closely? As I said before, if it is low risk, so the mother or the fetus or the labor, there's nothing to worry about. In that case, you don't actually need to do a CTG. I mean, you do a 20-minute trace, and then you can switch to intermittent auscultation. If it is medium or high, usually medium and high are used a bit interchangeably, that's when you're going to decide to keep the continuous electronic fetal monitoring. The C stands for contraction. So the contraction, and you need to check the rate, like how many contractions is she having every 10 minutes. We usually kind of talk per 10 minutes, like how many contractions you have per 10 minutes. The duration of those contractions, are they coordinate or uncoordinate? What do I mean by this? So in the ideal situation, you have coordinate contractions. In coordinate contractions, they tend to be linked to some type of malpresentations, for example, an OP. In the coordinate contractions, I mean, especially if they're persistent, they are going to affect the progress of labor. Okay, so the labor probably is not going to be progressing properly, and that's where you would be probably thinking of adding oxytocin infusion. All right, and the baseline tone. So the baseline tone, what that means is between contractions, whether the it's returning to baseline, and that, as I said, together with palpation of the tummy, you can see that there is relaxation between contractions. Of course, if it is like kind of tonic-clonic, so there is no return to baseline tone, that's not very good because that means that she's having, constant contractions and with no return to baseline, and therefore, of course, you are asking for fetal distress, basically. Okay? All right, the baseline rate. The baseline rate of the fetal heart. the normal range is taken as 110 to 160. Okay. If there is baseline bradycardia, basically if it is below 110, baseline tachycardia is above 160. And by baseline tachycardia, what I mean is not like an acceleration, because acceleration, I mean, if you have, let's say, a baseline rate of 120 and there is an acceleration, I mean, that's going to go up and down. But the baseline is in between accelerations and in between decelerations. And it's important to determine your baseline rate from the beginning, because once you know the baseline rate, you've established the baseline rate, and sometimes you might need to look at a long stretch of a trace. You can't just base yourself on just a tiny piece, but you need at least a 20 to 30 minute stretch of CTG, determine baseline rate. From there, then you can calculate whether there are accelerations or decelerations and the type of decelerations. So that's the BRA, baseline rate. And yes, causes of bradycardia, that is a low baseline rate. It can be physiological, so especially if you're dealing with a post dates, okay, so the gestation is more than 40 weeks. But unfortunately, it could also be because there's port compression, which is a good thing, or if there are congenital heart malformations in the baby, or congenital heart block, and there is a condition, systemic lupus erythematosus, which is an autoimmune condition affecting the mother. And unfortunately, the antibodies, which are antinuclear antibodies, they can cross the placenta from the mother to the baby and cause and attack the innervation of the heart and lead to congenital heart block, and even drugs or medications that the mother might be on, like benzodiazepines, which are used for psychiatric conditions. You need to. What this means is you don't need to take the history of the patient well and look at the notes. So if she's post-date, if she has a history of SLA, if she's on certain medications, then in that case, kind of know where the baseline bradycardia, where there is a baseline bradycardia. But of course, if there are none of these, it could signify cord compression. Tachycardia, on the other hand, with a baseline rate of more than 160, as I said, baseline rate, so not just acceleration, baseline rate, it could happen if there's excessive fetal movement. And again, that's why you have to look for at least 20 minutes to 30 minutes, right? Because, we know that the fetus normally takes breaks, and so even if the baby is moving, it will not continue moving excessively, all the time throughout the whole labor. And we also know this maternal anxiety can also make the fetal heart rate increase. Why? Because she has palpitations, so there's more blood going to the placenta, and therefore that will increase the fetal heart rate because of increased cardiac output. Actually, it's receiving more blood and therefore more cardiac output. Same with maternal pyrexia, increased temperature in the mother, and the same way that it will give her palpitations, it will give palpitations increase the tachycardia in the fetus. Also, if there is preterm, well, under 32 weeks, the fetus tends to have an increased heart rate. And of course, if there is fetal infection or chorionitis or chronic hypoxia, right, the last two, of course, being in very serious ominous conditions, that can also present with tachycardia. All right, the variability. Now, probably they're all important. So the baseline rate, the variability, the accelerations, they're all important. But probably the variability is the best or one of the best indicators that there is an intact integration between the central nervous system of the fetus and the heart of the fetus, meaning that it's probably the best indicator of proper oxygenation of the baby, right? Because ultimately we're doing this test, we're checking the fetal heart rate, during the Ctg, as I said, because it's an indirect measurement of the fetal oxygenation. If there is a lack of fetal oxygenation and there is a shift in the acid-base balance, the first place to be affected is the fetal central nervous system. Okay, it's like us. I mean, if our oxygen levels go down, of course, our brain stems are suffering, and I mean, we die basically. Okay, so variability is a very, very, very important, very important interpretation of Ctg. The normal variability is normally 5 or more beats per minute. We'll see some traces very soon. It's important that you don't confuse variability with acceleration, and there's a marked difference. I mean, as we'll see, with accelerations, you need a rise of more than 15 beats per minute. And this persists for more than 15 seconds. Variability is literally the line of the Ctg. It's wiggly all the time, right? And that wiggliness, that is your variability. If it is reduced, and more so if it's absent, that's ominous. That's probably one of the most ominous markers, because that means that the central nervous system is basically not receiving, I mean, the baby basically is not receiving enough oxygen, especially as this reduced or absent variability is prolonged. Okay, so for example, here is a trace. Okay, here is a trace where here is the normal variability. So you can see the over here, all right? I mean, apart from the accelerations, you can see, for example, in this part here, right, the twiddliness, that is the normal variability, okay? Normal variability. And just to remind you, Ctg, so between, I mean, this is quite standard, and I'm sure is the same in your maternity ward. I mean, this between one line and another, it's usually, that is 10 minutes. Okay, so 10 minutes. And the each little box is 5 beats per minute. Okay, so that's quite standard. I mean, of course, if in your unit the Ctg is a bit different, I mean, but ultimately, even if it's a bit different, ultimately this trace is the same. Okay, and if you compare this normal variability with this variability here, this is reduced variability. So you might tell me, how come the same trace first was reduced and then it was normal? Most probably in this case, the patient must have received, for example, betadine as a form of analgesic during labor, and so there was a temporary reduction in the variability, because of course even the baby ends up getting some of that betadine and while still in utero, and then most probably also the mother changed position and the variability improved, and some time passed as well and the variability improved. So there was like a temporary reduced variability which then improved. So that's fine. If it were to persist, or the more flat the line is, that is, as I said, potentially ominous, because it means there is decreased in oxygenation. The A stands for accelerations. Now, the accelerations, so it's different from variability. And when we see accelerations, we're happy because they are usually associated with movement or with stimulation. And it does show that there is fetal well-being, right? That the baby is happy. And it basically is when you have at least an increase from baseline by 15 beats per minute for at least 15 seconds. Now you can have a bigger rise than 15 minutes, so than 15 beats per minute, and the longer acceleration than 15 seconds. But to clarify, those are the minimum criteria. And ideally, an antenatal Ctg, right, should contain accelerations. I mean, especially, if she's in the early stages of labor or prenatally, like you're listening in. So, normally you keep, if a lady has come in, for example, because she hasn't felt the baby move and you're doing a Ctg, you normally, I mean, as I said, you give her 20 to 30 minutes like in this case, we give her 30 minutes. And just in case the baby happens to be a bit sleepy at this point, I mean, you keep on the Ctg till you start seeing accelerations. Okay, so it's very important. And as you see, so the baseline here is about 130, right? And then here you see a rise, right, from baseline. So that is not variability, that is an acceleration. There's a rise, which is about 20, actually, yes, it's about 20 beats per minute, and it lasts for, no, it lasts for at least 15 seconds. As I said, I mean, from here to here, you have 10 minutes. Okay, and also what's good about this that she's having some contractions, and with the contractions, I mean, not only is the variability good, but she's also having acceleration, so the baby is moving. So that's very good. Okay, we like when we see accelerations. Now, the D. The D stands for decelerations, and there are really and truly like three main types of decelerations. You've got the early decelerations, you've got the variable decelerations, and you've got the late decelerations. Now, the early decelerations, they are the ones which mirror contractions. So remember, we started off doing our doctor's bravado by determining the contractions. And here, like you can see two contractions happening. Okay, we're not seeing the whole trace, but we're seeing two contractions over here. And if we were to follow this line, at the same time that there is the contraction, there is a deceleration. And when the contraction ends, the deceleration ends and goes back to baseline with variability. And then when there is another contraction, again, there is a deceleration which starts with that contraction and ends with that contraction. Okay, so those are early decelerations. They mirror the contractions. They might not be present with every contraction, and the fall normally is less than 60 beats per minute from baseline. Okay, so if the baseline here, I mean, is over here, this line here, there is, a dip, but it's less than 60 beats per minute. Okay, and basically these are usually considered benign. So that's why it's important to recognize that they are early, not other types of decelerations. They're benign. They are very, very common as the mother is pushing, right? Or when the head is very well engaged and she is, in the last part of the first stage, and it usually happens because of pressure on the head. I mean, as the baby is very well engaged and about to start growing, there's of course pressure on the head, and it is considered, a normal physiological reaction. I mean, not all babies have early decelerations, but if they're there, especially as I said, I mean, if there has been a quick descent, or she's pushing, I mean, that is okay if you see them. You don't need to intervene or to expedite the delivery. Now we start coming to those decelerations which we are not very, we feel uneasy about. Okay, and there are the variable decelerations. So variable decelerations, as the name implies, they're variable both in occurrence, that is, with respect to the contractions. So some of them will happen with the contractions, so they look like earlies, and some will happen towards as the contraction is about to end, they appear. So they have a bit more of a late appearance. And they are variable in shape, in depth, and even in onset. And they can reflect cord compression, which is something that we don't like, because cord compression means there's less oxygenated blood going to the baby. So although they can be benign, right? And usually, if you change position for the patient, I mean, if she's lying on her back and she changes to one side, they tend to then, disappear. So there was cord compression on one side. I mean, you change position and it's better. However, if they start becoming more of them start being late, right? So although they're variable and you get the occasion in early, more of them start becoming late or deep, then that is significant because it might indicate that there is hypoxia or actual port polyps. Okay. When you get the shouldering is so when there is this variable deceleration, there is like an M which happens. So you get the shoulder before. So if this is the baseline, you get a shoulder before, which looks like an acceleration. And then you get the dip, and then you get the shoulder again, and then goes back to baseline. That is usually considered benign. So if many of your variables or all of your variables have this M shape or this shouldering, again, usually a change in position is all the patient needs. Okay? But definitely she's going to stay monitored. You need to continue your CTG because if they start becoming more late and start changing, then or there's a change in variability, you need to do something about it. So you need to watch that patient closely. And these are the variable deteriorations. So you see the contractions over here. And for example, this first one, I mean, you get the M shape. So this is the baseline. There's the shouldering, what looks like acceleration, but it's not acceleration because it's followed by this dip. This dip actually is more or less over. Once the contraction goes, you get then another shouldering up. So that is a typical variable. Same here. So this has a little bit, okay, it's slightly late, but more or less once the contraction is over, it goes up again. Same here, right? A little bit more prolonged. Same here. So these look more early and they have the M, right? And same here. Okay. And now, for example, as you are progressing, these ones over here, because there has been a bit of a loss in the trace when it comes to the contractions, or maybe there has been a change in the baseline for the contractions. Here you can't tell. I mean, they look variable, but you need to continue monitoring because we don't know the relationship with the contractions. Also, you need to adjust the belt in order to make sure that they are not becoming more of a late component. All right, then there are some variable decelerations which are atypical variable decelerations, and these mean that all of them are late, and they have a late onset, they're taking long to recover, and they're accompanied by decreased variability and baseline tachycardia. And if maybe there was some shouldering before, you start losing the shouldering. So in that case, something like this, for example, as you can see, the contractions over here, and for example, this one, this deceleration, there's no shouldering. I mean, the baseline is here, no shouldering. And it is happening late, right? Definitely after the contraction has happened. It's taking long to recover and to baseline. Again, here, you've got another one, and they're all late. They all are prolonged, right? You can see that the baseline is high. It's so this is not acceleration. This is the baseline. It's 170. Okay, the variability is also decreasing. Okay, so this one is ominous. I mean, so if she is fully dilated and she has been pushing, let's say, for some time, I mean, you're going to expedite the delivery. So I'm not sure if you're hearing some noise. And here it's 6 o'clock, 6 p.m. And as I told you before, our village has the feast this weekend. And at 6 p.m. here, there would be fireworks, I mean, which make a lot of noise. So if you hear noise, it's because of the fireworks, okay? That's all. I mean, so they're happy, not there's no war or anything going on. It's just the feast. Okay? I think they stop now. It's usually they do it at 6. Anyway, so let's continue. So the late decelerations. So the late decelerations are the ones which are typically associated with fetal compromise, hypoxia. However, now that we've been using CTGs for the past 50 years, And we do know that, of course, I mean, if you see late decelerations, you have to act in some particular way. And of course, if there is meconium, if you're dealing with high risk clinical situation, and especially if they're taking long to recover, there's an increased lag time, and these are more ominous. But even so, and I'm sure you've experienced this, that, I mean, you get cases where the CTG looks horrible, and you do a cesarean section, and the baby, is with Apgar score, the normal Apgar score. So, um, you wouldn't know unless you've delivered baby. Of course, there are situations if you have the means that you can do a fetal scalp electrode or fetal scalp blood sampling. If you have access to that, and if the mother is in imminent delivery, but she hasn't delivered yet, in order to measure the baby's oxygen levels. But of course, if there are no means, or there's CTG still looks very abnormal, then I mean, you're going to be moving towards delivery in that case. So this is what I mean by late deceleration. So you've got the contraction here, and the peak of the contraction definitely precedes the deceleration. So the deceleration comes practically as the contractions go away. And it's deep, it's prolonged, okay? So that is a late deceleration. And that's, I mean, does show that there might be hypoxia. All right, then there are some wave patterns which are definitely ominous. All right, and hopefully you don't get to see that. I mean, luckily they are not that common. That is the sinusoidal pattern. I'll show you what I mean by sinusoidal pattern. So this would be a sinusoidal pattern. Now, mind you, when you have a long trace, sometimes you do get some short parts where you get a little bit of this, but then, you change position for the patient and it disappears. So that, in that case, would be insignificant. But if it is prolonged, like here, it is there for at least 15 minutes, okay, that is not normal. And that can be a terminal pattern, all right? So baby is very sick. It could also be associated with severe fetal anemia or hydrops, right? Hydrops, as we mentioned, for example, and for rhesus isomalization, or if there has been, for example, parvovirus or any other cause of hydrops or fetal anemia. And as I said, if it is intermittent for short times and it changes with the patient, changes position, and that is okay. But if it is prolonged, like more than 10 minutes, and it doesn't change, and especially if you already are suspicious that it might be a case of hydrops, yes, I mean this. If you leave it there without intervening, there is a risk of stillbirth. All right, and so after you've assessed your CTG, you need to make your overall assessment and action plan. All right, you need to document this periodically, and you're going to decide, okay, do I need to intervene or not? Okay, do I need to add more oxytocin, for example? Do I need to do a vaginal delivery? Do I need to do forceps or vacuum? Do I need to do a cesarean? Do I just need to change position for the patient? Okay, so that's your Dr. C. Bravado. And again, the recommendations are therefore that you document the baseline rate, variability, the any decelerations and accelerations, and you say in your notes, as you're writing your notes, as you're monitoring the patient, whether the CTG is reassuring or non-reassuring and abnormal. And it is recommended, that the birth attendant would be documenting this ideally every hour. Okay, so it's either normal, meaning that all the criteria like baseline rate, variability, accelerations, etc., are all reassuring, or non-reassuring, basically suspicious or pathological. I mean, you usually put them under the same umbrella because that means you're going to have to do something about it. Okay, so that's enough talking from my end. And now I'm going to turn the stage to you, all right? And let's see. So I'm going to have, so what's the time? Yes, we're doing very well with time. We have an hour. So I have prepared, there are 14 different traces. And what I would like to do, right? I mean, so there's no right or wrong answer, as I said before. I mean, there's no right or wrong answer, but I would like you to participate and like we're going to discuss each Ctg. So we've got 14, so we could spend, let's say, approximately, we've got 14. We spend around 5 minutes around each one, and we will cover them all. Okay. So I'm going to show you the first case. And so the first case is a 25-year-old primate with no antenatal complications, right? She had a spontaneous rupture of membranes about 36 hours ago. It's clear liquor. She was having tightenings upon admission, and now because I mean she has had rupture of membranes for 36 hours, and she's going to be augmented. I mean she's going to be augmented for labor, so we're going to start oxytocin, and this is her trace. Okay, so I would like one of you. I'm not going to be directing questions at anybody, not to put anyone on the hot seat, but I would like a volunteer, please, to go through the description of this trace and like describe it, ideally using the Dr. C bravado. So I'll be saying like, okay, DR, which is determined risk. So from the history, what type of risk does she have? From the so doctor, then C, contractions, how many contractions, the BRA baseline rate was the baseline rate, the V, the variability, the any decelerations, and what would you do? So we need a volunteer, and whoever the volunteer is, if you can unmute. It would be nice if you can also show your face, but you don't have to. But if you can describe it to us, and the more we do, the more we manage to cover in this hour. So, volunteer, please.
Hello, Prof.
Yes, so we have Philip.
I'll
Yes, Dr.
volunteer.
Philip. Yes. And you did well, Philip, because the first one is the easiest one. So you did well
Yeah.
to be brave and to be the first one because it's the so please, the stage is yours, Philip.
Okay, so thank you. For the risk, this is a prolonged prom case.
It's true.
There's a
Just go
prolonged
back.
prom case.
Yes.
Yeah,
So 36 hours.
exactly. So that's a prolonged prom.
Yes. So it is high risk.
High
And
risk. It's a high
yes,
risk. There's a
and
possibility of
yeah,
Korean
and
meningitis.
yeah, and on top of that, you're also going to be augmenting. So now you're going to be intervening. So it is high risk, and she needs to be monitored. So very good, Philip.
Thank you.
So
And
that's the DR.
for C contractions, I do see about 4 contractions in 10 minutes.
You're right. We have 4
4
here. Yes,
contractions in 10 minutes.
yes, and 4 here. I mean, here there are about 3, and here there seems to be 1, 2, 3, 4, 5. But on average, it's 4 contractions. Yes, 4 contractions. Very good. Every 10 minutes. Very good. So that's the C. And then the BRA, which is the baseline rate. What would you say is the baseline rate?
For baseline, I'll go with 130.
Yes. Oh, sorry.
130 beats per
Yes,
minute.
it is 130. Exactly. And of course, to determine baseline, you look in between any accelerations. All right. So this would be the baseline. Yes, I agree with you. Yes.
Population at
There.
130.
Yeah. So
There's
this again.
normal B2B variability.
Yes, there
Variability
is.
is normal.
It
Yes.
is very good. So
And
that
for
if we, Mhm.
I do see accelerations.
Yes, there are many nice
There are
accelerations already.
accelerations as well.
Yes, very good.
There are some decelerations. These decelerations, okay, most of them are actually early decelerations,
Very good.
except for the first one. I don't know. It doesn't really go with the
It's true. It's true.
yeah,
And
but
it's also short, and then it's followed by nice accelerations. So
yeah,
they are, I mean, no, they are okay. You're going to watch it, but you're not worried about them. Exactly.
yes.
I
So
agree.
there are early decelerations.
Mm-hmm. And so your overall plan, what would you do next
Overall
after having
plan,
seen? Mhm.
overall plan. This is a reassuring CTG.
Yes, I agree
Um,
with you.
so I think we can go on with augmentation.
I agree.
Can go on
Yes,
with augmentation. Yeah.
very good, Philip. Well done. So we have example one, which I think we all agree. I don't know if there's anyone else who would like to comment about it, but yes, I mean, I would agree with Philip. Very good. Thank you, Philip. And
Thank
thank
you,
you for
Prof.
being the brave one to volunteer. But as I said, you did
Are
well
you good?
because
Yeah,
yes.
yeah, right.
So we have, I think, someone else, yes, volunteering.
Now, Pupuna, what's the man?
Oh,
I see a toilet kit to be a boy and a pan a time. At the Kunga, no, you bought me, no, you were
Hello.
hello. Yes,
Um,
hello.
wait,
Uh,
Ella.
so
Is it Ella or Elora?
Elora is. We have Elora, yes, who would like to volunteer. Because I'm not seeing who's speaking.
And I am sleeping.
I'm not sure if Elora would like to volunteer, but so let me share the screen again. I don't know what's happening now. Ah, here we are. So I stopped sharing for some reason. Not sure what's happening. I'm just going to stop sharing and I'll share again because something happened.
Just come.
So I stopped sharing and I'm going to start sharing again. I don't know what's happening. Somehow I lost. Yeah, here we are. Okay, yes. You should be seeing the screen. Are you seeing the screen? Yes. There you are. Yeah. So who is going to be the next brave volunteer? So we had Philip. Now who is going to be the next volunteer? The more volunteers we have, the more we'll cover. So should I start calling people out myself? I don't want to put you on the hot spot, but whoever feels comfortable. As I said, there's no right or wrong, and we'll be doing it together. Yes. So who's going to volunteer?
Okay, Prof. Maybe we can go through this. Maybe I can take this one as well, so
Are
that
you
the
sure,
subsequent
Philip?
ones.
Are you sure? I mean, we have, I think, about 17 participants. Well, if you count me, it's about 16 participants. But as you like,
Okay.
as you like. All right, Philip,
Okay.
you go. But then, please, we have someone else who will go. Okay, because I would really like to hear from you.
From other
And
people.
yes, so Philip, so we've got a 35-year-old primate. Okay, she has been induced at 35 weeks because of preeclampsia. And she had a UGR as well. I mean, the scan showed growth which was below the 10th centile. And her blood pressure at the start of induction is high, and she has proteinuria. And she had an ARM and rupture of membranes at 3 centimeters. That was 4 hours ago. She was started on oxytocin, and this is her trace. So let's just see the trace. This is her trace. Okay, so let's go through it bit by bit. So let's determine the risk. Determine the risk of this lady. So what is her risk, Philip?
Yeah. So first of all, there's a very high risk case.
Yes.
Preeclampsia at 35 weeks with
Exactly.
IGL.
Exactly. So
Yeah.
definitely high risk. So it's good that she's on the Ctg. All right. So that's your DR. Then the C, the contractions.
So for contractions, I would say averagely about 3 contractions
Yes.
in 10 minutes.
I agree with you. Yes. So that's
3 contractions
contractions.
in 10 minutes.
Mm-hmm.
For variability,
So it's the
variability
baseline
is
rate.
sorry.
The baseline rate.
Baseline,
Baseline rate.
yeah.
Yeah.
For baseline rate,
This is tricky. What do you think,
quite
Philip?
tricky. For baseline, I would say in 170 range.
Well done. Well done. Because the mistake which can be done in this case is that we don't recognize that the baseline rate, as you rightly said, is 170, and mistake the baseline rate for, here, for saying that it's about 100. I mean, and mind you, even if we're to mistake that, it's still bradycardia. But of course, if they take the baseline rate as being, 90 or 100, and then think that these are accelerations, that is the biggest mistake ever that can be done. So well done, Philip. I mean, yes, the baseline rate is 170, is that normal?
That's tachycardia. That's abnormal.
Exactly, that's tachycardia. And you can see both here and both here. I mean, here it's difficult to say what's happening, but definitely this here is a high baseline rate and not an acceleration. So not looking good, right? So that's the baseline rate. Then the variability. What do you tell me about the variability?
Variability, in my opinion, is reduced.
It is, and you're right, it is reduced.
Variability is reduced.
Yeah. And probably the best way to see it is from these two parts here. You can't really tell from here or from here. I mean, but here it is reduced. I mean, there is some variability, but it's reduced. Very good. Accelerations, what about accelerations?
Honestly, there are quite a few accelerations.
You think there are
Okay,
accelerations?
no. There are no accelerations.
There are no accelerations. No accelerations. No accelerations at all. Because if the baseline, so we determined it's 170, there's nothing above 170.
Yeah.
And even, all right, if you say this thing here, it's not, I mean, because 170 and it doesn't go above 100. Oh, sorry, above 15. So no, there are no accelerations. So that's A. Now, D, what about D?
For decelerations, I do see late
Very well.
late
Yes.
decelerations.
Very good. So there are all these here are decelerations, and when you compare them to the contractions, right, they all start basically after the peak of the contraction. So they're all late, and they're not variable because they're all late, okay? And you can see that they're deep, right? So they go from 170 down to 100, and they are all prolonged. Okay, so these are late decelerations. So what's your overall plan?
Overall plan, this is a pathological CTG.
Yes.
Because we have more than two, we have 2 or more pathological features.
Yes.
And so in this case, in my judgment, I would say maybe expediting delivery.
For sure.
That's
I
the
mean,
best option, yeah.
exactly. She was 3 centimeters 4 hours ago. So you'll do a VE, a vaginal examination. I mean, of course, if she happens to be fully dilated, you tell her to push and expedite delivery using assisted, using forceps or vacuum. But I mean, well, actually you can't use vacuum because she's only 35 weeks. So if you have to use an instrument, it has to be a forceps. But if she's not fully dilated, if you're not comfortable using the forceps, then it would have to be a cesarean section. So very good, Philip. Thank you. Thank you very much. So let's move on to the third example. So do we
Hello,
have,
hello,
yes,
hello,
Abigail.
Coach. Yes, please.
Abigail,
I just wanted to alert them. If anybody wants to answer, you can unmute and then answer the questions, please.
please do.
Or
I would
or you
really love
can
to hear
also
your
call out
voices.
the names. Yes, you can call out the
Shall
names,
I call out the names?
and
I
then
mean,
I think
it's
that
up
will
to
also make
you.
it
I
easy
don't
for
want
you.
to put anyone uncomfortable, but I can, I mean, if you tell me I can, okay. So I'll go by the way I'm seeing on the screen. Okay, so don't take it personally. I'm just going to go by how I'm seeing on my screen. So we've got Florence. Florence, can you hear me? If you can hear me, yes, thank you. Yes, you can unmute, and we'll go through this case
Orange, you can
together.
unmute. You can unmute.
Please, I can hear you, but my background is a bit noisy.
As you wish,
I'm
Florence. I mean,
actually in a car right now.
I see. No. If you're in the car, no, it's because it's not safe to follow this. Okay, no worries, no worries. Then when you arrive, maybe you can. So that's fine. So we'll move on to someone else. No problem. Thank you, Florence. So then
Thank you.
you're welcome, Florence. You're welcome. Okay, so the next person I'm seeing on the screen, I'm not sure if I say the name correctly. It is Zainab Abdul Mumin. Zainab Abdul Mumin. I'm not sure.
Yes, that's Zainab. That's correct. Zainab.
Okay.
Yeah.
So I'm not sure if you can hear us. If you can hear us, you can unmute. Maybe you can't hear us properly, or again, you're driving. No worries. Let's go on to the next one. As I said, I'm just following how I see you on screen. So we've got Dorcas Afram. Dorcas Afram. If you can
Yes,
hear
that's
us.
correct. Dorcas, you can unmute, please. Dorcas. Is Vida available? Vida.
Right now. Or perhaps I see Jessica. Is Jessica available? As I said, you don't need to be afraid or anything. We just go through it together. The idea is, that we practice together, and the more we can cover, I mean, we've got 14 examples. The more we can cover, the more we learn together. So Jessica, or perhaps Rebecca Frimpong. No. Mary Adarkwa. Sorry if I'm not saying your names correctly. I have to get used to them. No. Rebecca.
Hello, bro.
Hello, Rebecca. Hello.
Bro.
Rebecca, are you in a position to go through
So I
example
didn't
number
hear the
3?
question well. Hi, bro.
Hello, Rebecca. We can hear you.
Yeah, bro. Yes, bro. I said I'm still at the word. So I didn't get the question well.
Okay, you're on the word, right? And you can't.
Yes.
Okay, it's understandable. Don't worry, Rebecca. No worries. Thank you.
Okay,
But
bro.
thank you. Thank
You're
you.
welcome, bro.
Thank you, Rebecca. Thank you.
You're welcome, bro.
You're welcome. Thank you. Okay. So, maybe Irene Nsiah Akoto, are you available? maybe Jacqueline. Jacqueline or Evelyn. You don't need to be shy. You don't need to be shy. And I understand that, you're busy, but maybe Adwa Forkwo. Or Elora. Those are the ones I can see. No worries. No worries. Okay. And what we'll do, I mean, of course, feel free to, that if you wish to unmute, feel free, but just for the sake of those who will be watching the recording, I'll proceed and we'll go through it and we'll go through these because I would really like to showcase different examples of different races. Okay, so example number 3. We have a 30-year-old lady. She's a gravida 3 para 2. So Philip, I mean, if you wish, we can do it together. If you're available, I understand you're all busy. Okay, so we've got.
Well,
Yes, shall we do it together? I mean, it's more fun,
Yes.
doing it
Yes.
together.
Yes, please. Yes, please.
Yes. Okay, so we've got a 30-year-old gravida 3 para 2, and she had 2 previous normal births, both at 41 weeks, and now she came to hospital at 42 weeks actually, because she was reporting reduced fetal movements for the past 24 hours. She did wait a bit long, I think, but anyway. She was admitted at 42 weeks gestation for induction of labor. Prostin was inserted, to start off the labor, and it was given 4 hours ago, and now she's contracting, and Ctg was commenced, and this is her Ctg. So remember, she's 42 weeks, all right, and the 3rd baby, and she just had her prostin injection and prostin gel inserted to start ripening the cervix about 4 hours ago. So let's start by determining risk. So Philip, what would you think in terms of risk?
Prof, she
Yes,
came in
Abigail.
as 42 weeks gestation.
Abigail. Oh, Abigail, thank you. You're going to take part. Sorry. Yes, thank you. Yes.
Yes, Prof. She came in
Okay.
as at 42 weeks gestation, so that is also another risk for she being monitored on the CTG.
Yes.
And then yes, please. So that is
so that is the determined risk.
and
so
she also
is high
reported with
risk.
she also reported with low fetal movements.
So also making her high risk.
Yes,
Plus
please.
the fact that you're intervening. Now you're starting an induction, so that also puts
Yes.
her at
Yes,
high
so
risk.
it looks like we have three high risks or 3 reasons for the inductions for her to be monitored on the CTG.
Exactly. I agree. So that's your DR. So doctor, so what about the contractions?
The contractions, I'll say we'll have, I see like, is it 3?
It's about 2 to 3. I mean,
2
here,
to 3, yes,
they
please.
might be a little bit more clear. There, we're not seeing the full 10 minutes, but there are at least 2. And of course, here they give you the impression that they're not strong, but of course, from the CTG, you can't really determine the strength. What you can see is, yes, there are about 2. Here, perhaps there are 3, but there's a bit of loss of contact there. Okay, but here they're a bit more clear. So
Yes,
there are definitely some contractions. So that's your C. So the BRA, the baseline rate, what would you say is the baseline rate?
The baseline would be 100.
Exactly. And are you worried that it's 100? She's 42 weeks.
What did you say, please?
So she's 42 weeks. So I think,
yes, please.
Yeah, for 42 weeks, it's kind of acceptable. Because she's post dates.
Yes, please.
So
But
I'm
Prof,
not.
it looks like it's also descending to a 90.
It does. It does. Here,
Yes,
you're
yes.
right. So of course you're not fully reassured about it, which is
The
very good.
yeah.
Okay. So it's your BRA. So that's your baseline rate. Now the variability.
Um, I would say low variability.
Mhm. I mean, low to normal. I mean, there are places where
Yes, on
it's kind
the
of
on the other
okay.
side where you have the Kesa. Yes, please.
Yes. So
That's what I was also looking at.
this is a bit low. Exactly. This is a bit low. You would have preferred that it was all like this rather than having
Yes, from the
areas where it's like that.
beginning.
Okay.
Yes,
So
please.
it is reduced at times. So you're going to keep on watching this. So this your
Yes,
B.
please.
And what about the A? What about the accelerations?
Prof, I don't see any accelerations. I don't
Mhm.
know if yes,
Well
I don't see
done,
any
because well
accelerations.
done, because other people might have thought that these were accelerations, but these are not accelerations because what are they?
Mm.
And so if we go for our D, what would this be?
Um,
And there's one here.
this is I see. Yes, I see a deceleration, but
Mhm,
I wouldn't know if that is a late because it doesn't correspond with any contractions here.
mhm. Okay, I mean it's true. The fact that there is this shouldering before and after, I mean that actually would make it
Yeah.
qualify as a variable. And if so here, if this is the contraction, I mean this is kind of corresponding with that contraction. So this would be a variable which is happening like, with the contraction. But for example, this one here, right, which is also a deceleration, I mean this one, the trough doesn't correspond with the peak. So this has a late component. Over here,
Okay,
we
Prof.
can't tell. We can't tell what's happening because we don't have the contractions. So this might look like a variable, but you can't really tell because since the belt for the contractions is not picking up the trace well, we don't know what's happening here or here. So I mean, there are decelerations, yes, they might be, a variable component, but definitely you're going to keep monitoring the Ctg, adjust that belt, the contraction belt, in order to watch closely what's happening to this lady. So your your overall assessment and plan, what would it be, Abigail?
Um, yes. Prof, with my judgments, I would say we need to expedite delivery.
Mm-hmm,
If yes, please.
mm-hmm. And
Looking at the FHR.
yes, and
Yeah.
the variability, exactly. So,
Yes, please.
and I mean, one option could be that, for example, if she's lying on her back, probably I would change position. I would also, given this is baby number 3, I would definitely examine. I mean, because she might already starting to dilate. I would probably rupture the membranes if they're not ruptured already, and also to check whether there's meconium or not, and keep monitoring the CTG, and keeping in mind that this lady, yes, you might need to expedite delivery. Yes, very good, very good. Thank you, Abigail. Thank you. And sorry,
Thank you,
I mean,
Prof.
because you're the first one on my list. So somehow when I was reading the other names, I skipped you. So I didn't do it on purpose, just because you're first, and then there was Philip, and therefore I skipped you. Okay,
That's
sorry
okay,
about that,
so
but thank you.
that's
Um,
okay.
would you like to try example 4 as well? What do you think?
Okay, Paul.
Okay,
Okay. So,
okay, we'll do it together. Don't
Davida,
worry, we'll do it together. So
Davida,
example 4.
Davida 4 admitted at the labor at 39 weeks an
Yes.
hour ago. Okay,
Mm-hmm,
previous years
mm-hmm,
for placenta abortion at
mm-hmm.
10 late pregnancy into normal birth.
Exactly.
Okay.
Exactly. So basically, this lady, she started off by having 2 normal births. The third birth had to be previous cesarean section because of placental abruption, and now she's pregnant with baby number 4, and she came in at 39 weeks. Very good. So let's see her trace. So this is her trace. Okay, and let's start, assessing the situation. So DDR, the determined risk. So looking at her history, where does she stand? Is she low risk or high risk?
For high risk, she's a
She
previous
is
CS.
exactly very good.
Yes.
She's exactly, so that automatically, I mean, she has a scar. So yes, I mean, she is high risk. And
Yes.
yes, so that was determined risk. What about the contractions?
Okay, let me zoom
I mean, she arrived in labor ward only half an hour ago,
in.
and
Sorry, there was noise on the background, so sorry about that. Okay, the contractions go 1, 2, 4. 1, 2, 3. So from what I'm counting, I see 4.
yes, it's about 4 to 5. So if we take this from here to here, so 1,
Yes,
2,
please.
3, 4, 5. If we take this one here, you're right, it looks like 4
Yes,
because this seems
please.
to be the same one, and then this one, and this one, and this one.
Yeah.
Exactly. So it is about 4 to 5. So she's contracting, quite regularly, and again, it's not surprising because, I mean, this is her 4th pregnancy. So, and even though she's not being induced or augmented, I mean, that's understandable, and she's at 39 weeks. So that's your contraction. So she's definitely contracting on a regular basis. Then, so that's the C, the BRA, the baseline rate. So what do you think is the baseline rate?
The baseline 140.
Yes, I agree with you, which is fine. Okay, 140 is neither tachycardia nor bradycardia, so that's fine. What about the variability?
Yes.
So if we look at the variability, are you happy with it? I think variability is okay. All right. I mean, the best, you try to find a place like where you've determined your baseline rate, which is around here, and you see like the wiggliness of it. So baseline rate, if we're taking this as baseline rate, variability is okay. I mean, so that's normal. I mean, as I said, each little box is about 5 beats. So there are places where it's 5, and there are places where it's actually a bit higher than that. So it's just right. Okay. So that's your variability. What about accelerations? Do you think there are accelerations? I know it's a bit tricky, this one. I mean, really and truly, accelerations, there aren't really accelerations because the only times that it goes above the baseline, if we set the baseline as 140 and it goes more than 15, it's accompanied by either a deceleration before or deceleration after. So here, for example, there's a deceleration before. So you can't call these accelerations. I mean, even here, for example, you can't call these accelerations because this, I mean, is actually another variable, case of variable decelerations. And they're variable. So for example, here, this has a late component. So because the contraction here has ended, and I mean, the peak of the contraction is before the trough of the deceleration. So this is a variable because they're shouldering, but with a late component. And this one might have a bit of an early component, okay, but might have a bit of an early. This one here is late. I mean, doesn't correspond with any contraction. this we can't really know what's happening, but I mean, if it's there, it's a bit, between early and late. And this one here is also late. This one here seems to be corresponding. And this one here is just a little bit off peak, okay? And this one has an early, and this one is early. So these are variable decelerations. Variable decelerations, which you have to monitor, okay, because they are a bit deep and some of them have a late component. And so your overall assessment, basically, this lady, you're going to keep her on labor ward, of course, have her monitored continuously. And I mean, given the previous section, I would still prepare, take the bloods, put in a cannula. Of course, I will not start syntocin on, I will not start oxytocin because she already has contractions. And keep her starved, because if this Ctg gets worse, you're going to go for either cesarean section, or if the baby she's fully dilated, you have to expedite delivery, either through assisted vaginal delivery or cesarean. And also here, exactly, they haven't ruptured the membrane, so you need to rupture the membranes to look at the meconium. Very good. All right, so as you can see, now they're starting to get a little bit more tricky. So let's go to example 5. So example 5, as I said, I would like to cover as many of these cases as possible. If at least we manage to do 10, I would be happy. Okay? So we've got a primip at 41 weeks. So this primip came at 41 weeks. She ruptured her membranes 36 hours ago, so she ruptured her membranes at home. And by the time she arrived to hospital, 36 hours had passed. So now they're going to start augmenting labor. Actually, they started augmenting labor 12 hours ago, so she arrived at hospital about 24 hours after rupture of membranes. Then they augmented her, and she's been on augmentation for 24 hours. So she has been in labor for quite some time. Actually, it's true she's a primate, but she's been augmented already since 12 hours. She started off by having had a prostaglandin, then there was a rupture of membranes. Since she's been on labor for 12 hours, there has been a change of shift. And at handover, you're told that for the past an hour or so, the trace has been looking suspicious. And they took a fetal blood sample. So basically, they took a sample they nicked the fetal scalp and took a blood sample from there, which showed a normal pH, right? So it was kind of reassuring. And at that time, she was 6 centimeters dilated. Now, already, you might be wondering how come she still has not been delivered. If a prolonged labor, okay, 2 hours ago they did a fetal blood sample, and and they didn't follow up on that, and she's still not delivered. Okay, so the Ctg is looking like this. So who's going to volunteer? Maybe Philip, would you like to have a go at describing the Ctg?
Yes, Prof. We can go through.
Thank you. So let's go to her history. So is she low risk or high risk?
Okay, so this case is also a high risk case.
Definitely high risk. Yeah. Exactly.
High risk case.
She's been in labor for 12 hours, rupture of membranes, more than 36 hours. Mm-hmm. They needed to intervene. They had this fetal blood scalp sampling. And the Ctg has been suspicious for quite some time.
Yes.
So no, not good. She should have been delivered already. Anyway, but they didn't. They were waiting for you to come on call and to hand you over this case. So that was the term in risk. So the contractions, what about the contractions, please?
Okay. Contractions, from here I see 3 to 4 contractions,
Yes, it's
10
true.
minutes
I mean,
approximately.
here it's true. We can't see the full 10 minutes, but just looking here, there are at least 4. I mean, here we don't have the full 10 minutes, but at least 4, which is understandable. I mean, she's being augmented. So contraction-wise, I mean, it's at least 4 every 10 minutes. What about the baseline rate?
So for baseline rates here, I would say 170 beats per minute.
Yes. You're very good, Philip. It's 170. Because again, the temptation would be to say, oh, it's about, 160 to 165. But no, I mean, this is the baseline rate. Okay? This is the baseline rate, 170. I mean, it's true she's at 4 to 1 weeks, but I mean, she's been in labor for quite some time, with rupture of membrane for some time. So we're not entirely happy with the baseline rate of 170. So it is tachycardia. Yes. So baseline rate. What about accelerations? So if the baseline rate is 170, are there any accelerations?
There are no accelerations,
Well
and then
done.
also
No
there's reduced
accelerations.
variability as well.
Very good. So the variability is less than 5 because it doesn't fill one whole box. Yes. What about, very good. What about accelerations?
Accelerations are absent. I don't see
Accelerations are absent. What about decelerations?
Decelerations, yes, there are some decelerations. I do see some late. Sorry. These are early decelerations.
There are some earlies.
What?
For example, if you take this one, I mean, this is an early. This is an early. If we look at this one, this seems to be early to late. Yes. If we see this one, this seems to be early. And there, if we see this one, yes. So they are early decelerations, actually. There are early decelerations, even this one, they're early decelerations. But it's very good. And this shows also how good this mnemonic is, because by determining the baseline, then you can decide, whether these are decelerations or not. I mean, if by mistake we take this as the baseline and these as the accelerations, then we have a completely misinterpretation of the Ctg. So very good, Philip. All right, so there are early decelerations. So what would be your overall plan? I mean, just take you back to this. What's your overall plan?
Okay,
what
so
would you do?
for my assessment, this CTG is actually non-reassuring. I would say pathological. However, 6 hours ago, sorry, I've forgotten the hours.
Yes.
I think they said she was 6 c.m. Was that 6 hours ago?
Actually,
well, that was
this
a
was
handing
2
over.
hours. This was
2
2
hours.
hours ago.
Okay, sorry,
because
2 hours
they
ago.
did the fetal blood sample 2 hours ago. 2 hours ago, she was 6 centimeters.
Okay.
So for sure, she needs to be re-examined.
Yes.
Maybe those elucidations are because the head has descended, and maybe, she's for dilatation. So you can ask her to push. In that case, you ask her to push. And given that it's her first baby, I mean, you might need to help her, assisted delivery. But if she is not fully dilated, then
we'll have to expedite.
Go for cesarean. Yes, very good. Extremely good. Very good. All right, let's go for example number 6. So now we have a lady who is a gravida 4 but para 1. So basically she had 2 previous miscarriages. Okay, so she's a gravida 4 para 1, and she's been admitted at 39 weeks for gestation for induction of labor. Basically, they decided to induce her not only because of the 2 previous miscarriages, but also because she has gestation diabetes, which had to be controlled using insulin. And in spite of that, I mean, the glucose levels were poorly controlled, because she was, in spite of increasing insulin requirements, mean, she's very obese, right? Which of course was not helping her diabetes. And she had an ARM, and once she was 4 centimeters, and thick meconium was there, right? So there was thick meconium, and they decided to, let her continue the delivery, and they did a trace after 4 hours of doing the ARM. So just looking at this history, again, already it shouts at you that this is obviously high risk. You all agree this is high risk, right? It couldn't be, it is high risk. So let's have a look at the trace. So this is her trace. Okay, so she is now, as we said, 4 hours ago, she was 4 centimeters. 4 hours ago, she was 4 centimeters, and you get called in to see this trace, and it's like this. So let's go through it together. So we've determined the risk as being high risk, yes. And what about the contractions? Remember, she's morbidly obese, BMI of 41, but from what could be detected, how many contractions would you say there are?
From the chart here, I would say 5.
Yes,
5
I
contractions
agree. So
in 10
1,
minutes.
2, 3, 4, 5. Yes, very good.
Yes.
Here, probably there was loss of contact, because she's obese. But here you can easily count 5, which is fine. So this is your contractions. What about baseline rate? So the baseline rate, what would be the baseline rate, you think?
Okay, Prof. So here for baseline, this is quite
Tricky. Yes, I told you
yeah.
they start becoming more difficult.
Yeah. Baseline, I would say 140.
Yes, definitely
Yeah,
here
not
140.
to be
But
corrected. Yeah.
if you follow the trace,
Yeah.
what do you notice? So here it started off as 140,
Mhm.
but over here, what about the
It
baseline
seems to
rate
be
over here?
a change in the baseline.
It's decreasing.
Yes.
Exactly, it's decreasing a little bit. Even though here we only have a 20-minute trace, but there seems to be that trend, and definitely we're going to keep her on the Ctg to see what's going to happen. So very good. And what about, so we have the baseline, what about the variability?
Variability is good.
It's good,
Variability
yes,
is
because you have
is
at
not.
least 5. Yes,
Yes.
If you take this
Yes.
part here, and even if you take this part here, where the baseline is a bit low, it is just within the normal limits. There are some occasions where it's starting to become a bit reduced over here, but yes, the variability so far, there is variability. All right, what about accelerations?
Yeah, Prof. There are accelerations. I do see accelerations.
Yes,
I do
there
see.
is an acceleration here. Yes.
Yes.
This, because it comes after this deceleration, I wouldn't count it as an acceleration because it's in close proximity to acceleration. But these two here look like accelerations. Yes, probably these two are the accelerations. Yes. Okay. So what about decelerations?
Yes, Prof. There are decelerations
Hello,
for
Prof.
the first. Yeah,
Yes.
Abigail.
Yes, Abigail. Yes, Abigail.
No, not to answer, but then on the other sheets, would you say that this is a late? I think what's Dr. Philip was trying to answer the other parts. You see, there is this acceleration, and on the other parts, on the contraction side, there is a contraction. So, would you count this as a so late?
This one here. So
Hello,
I
can you hear
would.
me?
Yes, I can hear you. I can hear you, Abigail.
Prof, where's your Keza? I can see your Keza. No, on the other parts of the
Over
sheets.
here, yes. So these are definitely now
On
becoming
your right
late.
side.
Exactly. These are now becoming late because, for example, this one here, okay, this one here is,
Yes,
even though
please.
this
Is it
looks
also
like
counted
it's
as
big,
late?
it's late. This is late. Why late, not variable? Because, I mean, you don't have the typical M shape. Now, to be honest, even this doesn't have the typical M shape, but the fact, I mean, this you can't call it an acceleration. Even these, you can't, well, these, possibly this one is an acceleration. But yes, these would be late, right? Variable to late. I mean, this looks like a variable. This is more of a late component. And then, I mean, if you look at this one, right? This one is, again, this looks like late because the peak comes before the trough, okay? And then this one,
Yeah.
this is also has, I mean, a bit of a late component. This one is right with the contraction. So again, these are variables, although they look worse than the previous case, but these would still look as variable, but more ominous in the sense that there are a number of them which are late, and also they are deep. I mean, look at this one. I mean, it's going down to 60, for example. And that, together with the fact that there is the falling baseline, the reducing variability, you know, and the history, all right, the history, the fact that, you know, the high BMI, the diabetes, the thick meconium. Okay. Yes, I mean, this for sure. I mean, she's been last examined 4 hours ago. She definitely needs to be examined. And, you know, unless she is fully dilated and ready to start pushing and you go to expedite delivery, you have to consider cesarean. Now, of course, doing cesarean is also a bit tricky because of her BMI. So in the ideal situation, she's fully dilated and you expedite delivery. If she's not, I mean, you know, there's an increased risk of losing the baby, basically. Yes. Very good. Yes, very good. All right. Any comments, any further comments on this before we proceed to the next one? No? Okay, so let's proceed to the next one. All right. So basically, you're on labor ward and one of your colleagues calls you to review the Ctg of a lady who's in her second pregnancy, who had a previous cesarean. So first baby was born by cesarean section, let's say because of breech, for example, and she's now in her delivering her second baby, and she decided to try to go for a normal vaginal delivery. But there's bradycardia, and as you enter the room, this is the Ctg that you see, which is Ctg that you don't really want ever to see, but this is what you're faced with. All right, so let's go through it together. I mean, this is, of course, and definitely you have to do something about it, right? And I'm sure you all agree. So if we look at terminal risk, I mean, she is high risk, right? She had the previous section, and there is bradycardia. And you can all see the bradycardia over here, right? This is like shouting out at you that you need to do something about it. Bradycardia at 80. Now, to be honest, I mean, this is probably the point where you were called in. But in reality, maybe you should have been called in well before, because although here, okay, it's obvious this is bradycardia, but if, I mean, the 10 minutes before and even like the 15 minutes before, already there were signs showing you that there is a problem. Why? Because, so first of all, looking at the contractions, you can't really say what's happening. So this seems to be to me that there is no relaxation between contractions. So there is an increased tone. You can't really tell what's happening. So that doesn't look good. But even though it doesn't look good there, or at least let's say there's loss of contact or whatever, here, you know, I mean, you can see that the baseline is not normal. I mean, here the baseline is 90, all right, 80, and 75, Okay, so the baseline here is not normal, and then it's persisted not normal. What probably happened, I mean, the fact that maybe you weren't called in before, what probably happened by mistake, the baseline was thought to be this one here. No, thought to be this one here, but even so, even if that mistake was done and the baseline by mistake was thought to be up here, still there is sorry, wait. I made a mistake. And I apologize. I'm going to rewind all that I've said before. So sorry about this big mistake from my end. Let's rewind a bit. Let's go back. So you're called in by one of your midwives because she's delivering a previous section, okay, and you're called in because of the bradycardia. You all agree that this is the bradycardia over here, right? We're going to go through the Dr. C. Bravado. So determine risk, high risk because of previous section and the bradycardia, which is here. Determine risk, so high risk. Contractions, you can't really tell what's happening with the contractions, but most probably there are contractions, but they're not resting in between. Okay, but you can't really tell what these contractions are doing. The baseline rate. So baseline rate here is obviously 80, but here before, so when there is where I did the mistake, I was going to fall for it myself. And the baseline rate is actually up here, so it's around 160. Right, it's around 160, and it's falling. All right, so that's the baseline rate. No accelerations. I mean, no, can't really. I mean, maybe this, but not really an acceleration there. But then there are, the variability is reduced, right? Variability is definitely reduced. Accelerations or accelerations, and then there are the decelerations, which are these, right? Which already these decelerations, although you can't tell whether they are early or late, but definitely they are prolonged. And I mean, if you were to assume, for example, that this was a contraction, I mean, this is late, and they are persistent, they're persistent deep, and they persist. And so these are late decelerations, or at most they are variable, I mean, because you can't tell with the contractions, but they're definitely deep. So, in my opinion, the doctor, I mean, should have been called in before, right? Rather than waiting for this bradycardia. I mean, it's true that, I mean, because even if you make the mistake that I was going to do in the beginning, where you say, okay, this is the baseline rate and these are the accelerations, I mean, still, this is low. And in reality, I mean, this is not the baseline rate. This is the baseline rate with the decelerations. Okay? Accelerations, which then, of course, persist. And that, to me, I mean, is very typical of cord compression. Cord compression, I mean, possibly cord prolapse. I mean, we don't know if this patient, I mean, had a breach or not. And definitely, I mean, irrespective of what's happening, I mean, unless literally the mother is pushing, but I don't think she's pushing yet, you need to do immediate cesarean section or you're going to lose the baby. Okay, so this is the sort of thing that you would have needed to be called in, and had the birth attendant interpreted the Ctg properly, all this wouldn't have happened, because even at this stage, I mean, they've already been with this bradycardia for 10 minutes. Already you're risking that even if you do the cesarean section immediately, the upper score is going to be very poor. Okay, so let's go. I mean, I would really like to, I know we're running a little bit late now, but I would really like to come at least to example 10, if you don't mind. So we'll just have 3 more to do. Okay, so we've got a primate who was having her delivery in a private clinic. Okay, and in the private clinic, there was no doctor. I mean, she was being followed up by the midwife. I mean, here in Europe, I mean, we don't have them in Malta, but in Europe, there are places where if you are low risk, you can decide to give birth in a birthing center with a midwife or with a doula. I mean, with a birth attendant. But in this case, you know, she was referred because during auscultation, there were decelerations. And those decelerations had been going on for 3 hours. No good, not good. And the reason why they were delaying in getting her to hospital, because the woman was very afraid of needles. You know, very afraid of needles, very afraid of intervention. She wanted to have a normal delivery, and she had been trying to deliver without needing to go to hospital. However, eventually she consented to be transported to hospital by ambulance. And before leaving hospital, the head was, I mean, the head was well applied, and she was 8 centimeters dilated. However, the head was an OP, which can explain why she hadn't delivered yet. And she arrives at your unit, and a Ctg is commenced. And this is her Ctg. So, looking at the case, I mean, she is high risk because already she had been having decelerations, and by the time she came to hospital, she had been having decelerations for 4 hours. Okay, so she is high risk. And if you look at the contractions, she's been having contractions. So contractions, we have about 1, 2, 3, 4, 5, about 5 contractions in 10 minutes. So she's contracting well. As regards the baseline rate, what do you think is the baseline rate? So Philip or Abigail or any other volunteer, what do you think is the baseline rate?
Okay, Prof.
Yes, yes, Abigail.
So okay, 150.
Yes, yes. So the baseline rate. So this is your baseline. So it's 150. 150 to 145. Yes, so very good. So this is the baseline rate. So here,
Yes,
for example,
Prof.
it's like
145 to
150.
150.
Yes, so that's your baseline rate. Yes. Then, as regards, so the V, the variability, about the variability.
I would say the variability is okay. Philip, please go ahead.
Yeah.
Yeah, it's a bit
Yeah.
reduced. I think it's a bit reduced, right? I mean,
Yeah,
so
it's quite
if you
trivial.
look here, where you have a bit of the longest, I mean, it's reduced. Here it might be just okay, but no, I mean,
Prof, I can see your Keza. Okay, I can see it now. Okay, I can see it now.
Yeah, I mean, so variability is reduced. I mean, because variability, like each squiggle. So even here, I mean, you know, it's not more than 5, so it is reduced. Variability is reduced overall.
Okay.
So accelerations. Do you think there are accelerations?
No, there are no accelerations.
Well done. No accelerations.
That
Very
happen.
good. And what about decelerations?
Yes, on the latter
There
part,
are.
is that a late deceleration?
They are.
Yes.
On the
Yeah.
last part,
They are.
yes,
I
please.
think actually they're all late, because if you look at the contractions and you follow the lineup, so this is late as well, and this one here is very late because the contraction is over here. So the contraction, the peak is here, and it starts basically when the contraction stops. You've got the deceleration. This one as well is late. This one as well. This one as well. I mean, you get the contraction, and then after there's the deceleration. Same here. So they're all late. They're all late. All late. And they are getting worse. You're right, okay. They're getting worse. They're getting deeper and wider. So late decelerations. So what is your, I mean, overall assessment? I mean, is it reassuring or not reassuring?
Prof, this is a non-reassuring CT,
Definitely not
coupled with the
reassuring.
fact that baby is also in more more position, sorry.
Exactly. I mean, here, I mean, it was OP, okay?
Oh,
But I mean, these late decelerations, I mean, you need to examine. I mean, she was 8 centimeters before she left the private hospital. So, I mean, you need to examine, and again, you need to expedite delivery. I mean, hope that by the time she was transferred, now, I mean, she's fully dilated, and right, they're going to assist and expedite the delivery. But if she's still stuck at 8 centimeters, you need to consider it. Yes, so let's go to our 9th case. So we've got a 39-year-old, gravida 4 para 3. So she's in her 4th pregnancy, and she comes at 31 weeks because the past 24 hours she hasn't been feeding her baby very well. So she had reduced fetal movements. So automatically, reduced fetal movements will make her high risk, right? And she's at 31 weeks. So let's see this Ctg that we have at 31 weeks. So let's start with contractions. Remember, she's 31 weeks and her presenting complaint was reduced fetal movements. Does she have any contractions?
yes, Prof.
There are.
I can count between two to three contractions.
You're right. You're right. So even though she's still 31 weeks, she already has contractions. Very good. So what about the contractions of baseline rate? What about the baseline rate? And remember, she's 31 weeks.
Yes. Baseline rate is at 160.
Yes,
160.
I agree with
Yeah,
you.
160 bits.
It's
However,
160.
it was stated below 32 weeks. There's always a possibility of high, or let me say tachycardia.
Exactly. So that is acceptable. Exactly. It's acceptable that it's at 160. I mean, after all, she's still 31 weeks. Very good. What about the variability?
Variability is reduced.
Definitely.
Variability is
It's reduced.
Yes.
It's reduced. So there is some, but it's reduced. So even though she's 31 weeks, you would have expected better variability for sure. Very good. What about accelerations?
There are absent accelerations.
You're right. They are absent. You're right. Very good. And so let's now, what about decelerations?
And for decelerations, there are delayed,
There are
late decelerations or late decelerations.
They are late. I mean, because you see the contraction here, and basically once the contraction stops, the deceleration is there, is quite deep, right? And it's not just the one-off. I mean, you've got here as well. You see the peak of the contraction, and then the trough comes after. And also, it takes a long time to recover. Okay, so yes, so your overall, what's your overall assessment and plan? So she's 31 weeks, right? Reduce fetal movements.
We reduce fetal movements. Prof, this is more of a suspicious to pathological Ctg.
And so what would you do? Let's say it's the first time you're seeing this patient, what would you do? What would you do?
I would take a scan.
Very good, Philip. Excellent. You need to do a scan, exactly, because you need, I mean, you can't just say, okay, I'll do cesarean section. I mean, but she's still 31 weeks, right? And of course, even if you have your NPICU, I mean, the fact that this baby is born very premature, I mean, without having, for example, given DEXA to the mother, I mean, and waited, maybe because, I mean, you need to wait 24 hours if you're going to give DEXA. And so you need to do a scan, I mean, because it might be a case of eye drops or I mean, you need to assess what's happening. And you definitely need to open, even the pediatricians, and I mean, you, and you need to keep monitoring and decide, I mean, whether or not basically safer to leave the baby in or safer to deliver.
And then, Prof,
Yes, yes.
sorry, Prof. So in this case,
Mhm.
would you say an umbilical artery Doppler will be the
It
best
would be
candidate?
very useful, very good. It would be very useful because it might be a case of cord compression. I mean, or let's say cord entanglement, for example. So yes, doing a Doppler is very important as well. So ultrasound and Doppler, yes. And again, I mean, if the Doppler is fine, we would, cautiously keep on monitoring and wait. And but definitely she can't go home. I mean, she would need to be observed. And probably, especially if the Ctg improves, I mean, I would probably consider giving dexamethasone to the mother because,
Yes.
in case that you need to expedite delivery and the baby is born prematurely, I mean, you improve a bit the prognosis when the baby goes to NPICU. So this would be a bit of a good situation. Yeah, very good. But you've managed her very, very well. So she's very lucky to have come to your unit. All right, let's take a yes, Philip, you want to say something?
No, Prof. Please go ahead.
Okay. Yes. So let's take a last example 10. So we've got a 41-year-old lady pregnant for the first time with no antenatal complications, luckily. She was admitted at 5 centimeters and she had meconium staining when she was admitted, and that was yesterday night. Okay. And 3 hours later, so at 2 a.m., she was examined again. She was 7 centimeters. But then, because the unit was very busy and maybe a bit understaffed, she wasn't examined until 8 a.m. So 6 hours passed where she was not examined, right? 6 hours passed and she was 7 centimeters meconium. And at 8 a.m., when there was the change of shift, she was still 7 centimeters dilated. So this already doesn't augur well. And an hour later, they decided to put an epidural because the mother was very tired. And they started syntocinon 10. So remember, she has been at 7 centimeters now for 8 hours. And there was a trace done, and lo and behold, this is how it's looking. So, I mean, just at a glance, does this look good or not?
Well, this looks very bad.
Exactly. This is the typical sinusoidal pattern.
Sinusoidal pattern, yes.
Sinusoidal pattern, which I hope you never get to see in your life. Actually, you never end up in a situation like this, where this was obviously she was mismanaged, all right? She was heavily mismanaged, onium stained, and then left for, all that time without being examined. I mean, and I mean, she should have been examined, earlier than that, and action should have been taken while she was still 7 centimeters. I mean, while she was, and when she got stuck at 7 centimeters, so I mean, she should have been examined ideally around, 6 a.m. and started with syntocinon at that point. I mean, but this is sinusoidal pattern. So, but again, if you use the Dr. C Bravado, so the term risk, she's high risk. I mean, there was meconium, and she's also, 41 years old. And the contractions, I mean, there are contractions, right? About 1, 2, 3, 4, about 4. And the baseline rate, you can't really say where the baseline rate is because this is sinusoidal pattern. Of course, there are no observations. decelerations you can't, I mean, this is sinusoidal pattern, so they're not really decelerations or accelerations, it's sinusoidal. And it's usually a preterm in your, baby. There's a big chance of intrauterine death here. Okay? And therefore, I mean, this baby needs to be delivered ASAP. So, delivered ASAP means by crush section, basically, if you want to save that baby. And even if you save that baby, there is very likely that the baby will be born with a low Apgar score. Okay, docs. So we've managed to do 10. I think you've managed the patients really well. So if I were to be delivering my baby, I would feel very safe coming to your delivery suite. So thank you for that. I think many of our colleagues were probably either shy or, you don't have to be shy. Please do take your time to go through the recording, to go through the recording again, because this is very, very important. I mean, can I ask you, Abigail, yeah, do you routinely use Ctg in your practice? How does it work on your delivery suite?
Yes, Prof. We use a CTG there. We actually have two, so one for each department. Yes, please. So we use it. Yes, please.
Very good. And I mean, do you also already use? I mean, Philip, do you already use this Dr. Sibravato? Had you heard of it before, by any chance?
Yes, Prof. Yeah, we use
Okay,
the
very good.
Silver.
I'm glad. I'm very glad, because to be honest, I mean, in our unit, we had introduced it, I would say now, about 15 years ago. And it has helped us a lot. I mean, I do remember a time when we didn't used to adhere to it. I mean, we didn't know about it. And then, to be honest, I mean, I think it was 2005, I had gone up to the UK to do an also course, is advanced life support obstetrics. I had heard about it for the first time. And then when I came back, we introduced it to our unit. And like that, I think, I mean, first of all, it has empowered, everybody, like the midwives, the doctors, junior doctors, etc., and in order to be able to interpret CTGs. And it has also reduced the amount of times that you get called in to see CTGs, because once you know how to interpret it, and therefore when you get a call to go and see a CTG, you know that then yes, there is a problem, because once everyone knows how to interpret CTGs, it makes it safer for everybody. So really well done, Philip. Really well done. Very good, Philip, Abigail, all of you, and very good. And so, are there any questions at all? Are there any questions or any clarifications that you would like? I promise you also this weekend I'll be sending you the PDFs of all these presentations, and I will probably, Abigail, I'll be sending them to you. I'll be sending to you.
Yes, Prof. Surely.
If I'll send them to you one by one as a separate email, so that because I think if I send everything, that might be too large a file, but I'll send them one by one, and each email will have the title of the presentation, and they will be as PDF, so they won't be too big. Because it would be a good idea, I think, that we send them off to the participants, because of course the test will be based on those slides. Yes. Yes, Florence.
All right, thank you.
Yes, I think Florence raised the hand. Florence raised the hand?
Yeah,
Florence,
Prof, I do have a question.
Yes, please.
Yeah, please allow me to take us back a bit to, I think it was one of our examples. I've forgotten the number. However, it was post-datism. It was at 42 weeks.
Let me go back to it. I'll find it for you. Give me a
Maybe
second.
example 3 or 4.
Let me
One
go
of
back.
them.
I'm just so otherwise not sharing. Let me just switch this off and I'll switch it on again. Okay. So I have share. Okay, so let's go. It was someone post dates, right? So
Yes, post dates.
let me find it. This one, this one, this one. It was the 43-week, I think.
42 week. Yeah, 42 week.
This one. No. 41 weeks. There was one at 41 weeks. And there was
Yeah, I think that's the case. 41 weeks, but had induction of 42 weeks. I think
42
that's
weeks.
yeah. I think
It's coming.
yes.
It's coming. I can't find it now. Let's just go through them quickly. I can't find it. I'm sure there was one. I remember one.
Yes.
So let me just share the screen so we check them out together. So this one was the 25-year-old primate. This was the 35-weeker.
Yes, this
Was
one.
it this one? This one it
Yes.
was? Yes, 42 weeks. Yes, there she is. Okay. Yes. So
Yeah.
and there's the
So
trace.
with this one, with the baseline,
Mhm.
with the baseline, I remember you saying it's normal at 100. This is approximately at 100, right? Baseline
Over here it's at 100. To be honest, over here it's a bit lower than that. It's
lower. Okay.
basically 90. But I mean, overall,
Yeah.
given that the variability is fine, I mean, I would not be so worried about it, and given that she is 42 weeks.
Okay.
So it's acceptable. It's acceptable. Of course, she's going to continue being monitored, but the fact that, I mean, she's 42 weeks and the variability is fine, I mean, that doesn't worry me. Of course, what's then worrisome is the fact that she has the variable decelerations, with the M shape. So she definitely needs to be monitored closely, basically. I mean, even here, we don't know what's happening here because the contractions are not being picked up. Yeah. So
Yeah.
what was your question? What would you like to?
Yeah. So, Prof, I would like to know, with
Mhm.
post-date cases, when should we be worried about possible maybe bradycardia? Let's say in the setting of normal variability, possible accelerations, and then early decelerations. When would we say maybe there's bradycardia?
It's a very, very good question. It's a very good question. I would, for sure. I mean, if, for example, this baseline was at 80, I definitely would not put it down to post dates. So, for example, if we compare it to, let me go to that one which had the obvious bradycardia. I mean, this for sure is abnormal. I mean, even if she was 43 weeks, that is abnormal. And very often, I mean, when there is bradycardia, which is pathological, it would also be accompanied with reduced variability. Right. So imagine you just saw the trace, from here onwards, and she happened to be 42 weeks. I would be very worried with that Ctg because it's basically a straight line, no variability.
Yes.
I mean, even though she's 43, that would be abnormal. So I would always suggest that you see the overall picture. I mean, you see, okay, take the history, etc. You see the overall picture, and you take the baseline together with the variability. So those two go together. I mean, the variability actually has a lot of weight. And then, of course, if there are decelerations. I mean, here, if I was presented only with this part here, I mean, okay, it looks like there are no decelerations, but of course there are no decelerations. I mean, the baby at this point has given up,
Yes.
So So that would be, I mean, pathological, seriously pathological. So I'm not sure if I answered
Yes.
your
Yes,
question.
Prof. Yes,
Yeah.
Prof. Thank you very much.
Thank you. Thank you for the questions. It was a very good question. Okay. Are there any other questions?
Well,
Or
I think I see Florence hands up. I don't know if she has a question.
all right.
Yes,
Florence. Okay.
yes, please. I need some
Yes.
clarification on the
Yes.
baseline, like how to determine your baseline rate. Do you pick on average or at the start of the graph, the trace, like maybe the first figure you get on the graph, or you take it based on the average? How to determine
Okay.
the baseline?
Okay. Okay. It's a very good question as well. Okay. Very good. So let me just go back to a trace and we have a look. So let's find a relatively normal one. Let's go to the ones in the beginning. Let's go to a simple one. This one. Yes, let's go to example one. Okay, so if everything is fine, I mean the baseline really and truly will not change that much, right? So this was a quite straightforward normal CTG. So basically, of course, when you're determining the baseline, you kind of ignore where there are the accelerations. Had there been decelerations, I would have ignored them, and you try to go for a stretch. Like in this case, for example, this is approximately 130. Okay, then you find another stretch where there aren't accelerations or decelerations. So let's take this one, and again, I mean this looks like 130, right? And then I go, again over here, for example, and again it's about 130. To be honest, over here is more like 120, but on overall, the majority of cases, it was in the region of 130. Now you might say that it is between 120, 130, and make it as 1 to 5. It's still okay. What would be important is if the baseline is falling, so as the CTGs is progressing, the baseline is falling. And in fact, there was one, let me find it, where the baseline was falling, and here it is. So in this case, I mean, where here it started off as being 140, and here, I mean, it is, there are times when this baseline is about 130, then in that case, I would comment that, at, let's say, at 10 a.m., and baseline was 140, and at 10:20, and the baseline was at times going down and below. Okay, so and very often when you have a trace, I mean, you are monitoring the patient. I mean, because if it's looking non-reassuring, you're monitoring her and like assessing. I mean, at least every hour. And if you started off with the baseline being, let's say, at 10 a.m., the baseline being 140, and now at 11 a.m., I mean, it's 120 to 130 consistently. I mean, you make note of that, and because it is significant. But again, I mean, you see that in the overall picture. I mean, if the variability has remained fine, or maybe the patient, let's say, was given analgesia in the meantime, so maybe that's why the baseline went down a bit. I mean, you see it in the overall. And when I said in the beginning that, at least every hour, I mean, even if it's a ratio and CTG, every hour you assess. I mean, when you're assessing the whole Dr. Bravado. So you're checking the contractions, checking the baseline again, checking the accelerations, decelerations. So you see, sorry, you check whether there have been any changes. Sorry about that. My headset fell. Sorry. So you check whether there have been any changes. So I'm not sure, Florence, if I answered your question.
Yes, please. Thank you.
Thank you. And thank you for the question. It's very, very relevant. Are there other questions? Seems that there are, no questions in the chat either. And I think, Abigail, we're meeting again next week, right? Just checking my diary.
Yes, please, Paul. Yes, please.
And that is.
I think can we have the flyer on the screen, please, Richie?
So that's on Monday, 1st June.
Sure.
I think I'm just checking what's next. I think it's shoulder dystocia, but I'll just confirm.
Prof is on the screen now.
Yes, there it is. Yes, it's shoulder dystocia.
Shoulder
breech delivery.
dystocia and breech delivery.
Yes, that's a nice one.
Yes,
Shoulder
please.
dystocia
Yes,
will be going through
Thank you.
the another mnemonic. It's called helper mnemonic, and then there's breech delivery. Very good. And that will soon bring us to the one before the last, which is very good. Sorry, can you excuse me a second, just because my daughter is calling? Excuse me a second.
Thank you so much. Thank you so much. Thank you, colleagues, for joining. And then we will see you all next week, Monday, 1st June, for the next session. Thank you so much, Prof. Yes,
just because
Prof.
my daughter was calling on the phone. Yes, but
Oh,
sorry.
sure.
Yeah, sorry about that.
Sure,
Sorry,
Prof. Yeah,
so
that's
you were
fine.
saying, sorry.
Yes, I was ending the session if there are no more questions.
Okay.
And then yes, please. So you end the session, and thank you so much for another insightful presentation. And we'll be expecting the PDF, so I'll share it across to the other colleagues.
As soon as we cut this call, I'll be sending them, because I think
yes,
we
Paul.
should send them off to the participants, because they need to start revising.
Yes,
Thank
Prof.
you.
Yes, Prof. Thank you so much.
Thank you so much. Have a nice
Have a nice
weekend.
evening. Sure,
Thank
you
you.
too.
Thank
All
you so
right.
much. Thank you.
Bye. Thank you,
Bye-bye.
colleagues. See you next week,
Thank you.
Monday.